Hello everyone, my name is Jacqueline Hausner and my tech talk is titled Simulation at the Edge, Technology-Enabled Training for Austere Medical Environments. Most modern medical education is still built around the assumption that providers will work in a highly resourced healthcare system. We train in hospitals with advanced imaging, specialist consultation, reliable communications, abundant personnel, and rapid evacuation capability. Operational medicine often looks very different. A provider operating on a ship, in forward surgical elements, during disaster response, or in a remote humanitarian environment may have limited imaging, minimal blood products, delayed evacuation, degraded communications, and little access to specialty consultation. These realities fundamentally change not only how medicine is practiced, but also how providers need to train and work. This presentation focuses on emerging technologies including mobile computing, telemedicine, wearable systems, distributed simulation, and immersive training platforms are changing the way medical personnel prepare for austere operational environments. I'll discuss the current state of these technologies, how we relate to modeling and simulation, and how they are being used operationally today and where they might be headed in the future. Austere medicine is not simply hospital medicine performed in a different location. It represents an entirely different operational problem set. These environments may include battlefield medicine, maritime operations, prolonged casualty care scenarios, disaster response, humanitarian assistance missions, Arctic operations, or remote rural environments with limited infrastructure. A shipboard surgical team with limited imaging and delayed evacuation requirements has fundamentally different training needs than a hospital trauma center. In many operational settings, providers may face delayed evacuation timelines, limited blood products, restricted imaging capability, minimal staffing, communication breakdown, equipment limitations, environmental stressors, and prolonged patient management responsibilities, just to name a few. In conventional hospital systems, definitive care may be minutes away. In austere medicine, providers may need to stabilize and manage critically injured patients for hours or even days before higher level care becomes available. These constraints significantly increase cognitive workload and decision complexity. As a result, simulation becomes critically important because providers must rehearse these operational realities before encountering them in real-world settings. The challenge no longer is simply performing a procedure correctly. The challenge becomes making decisions, prioritizing resources, communicating effectively, and functioning under uncertainty while resources are constrained and the teams are stressed. Traditional simulation centers remain extremely valuable for procedural training, team dynamics, and standardized education. However, many traditional simulation systems are designed around assumptions that may not apply operationally. Most simulation centers assume that there will be stable electrical power, reliable communications, abundant supplies, immediate specialist access, rapid patient transport, and controlled environments. Operational medicine frequently lacks many of those advantages. For example, maritime medicine introduces challenges such as prolonged evacuation timelines, ship movement, confined treatment spaces, limited personnel, and communication delays. Similarly, disaster environments may involve disrupted infrastructure, limited transportation capability, and overwhelming casualty volumes. If simulation only recreates ideal hospital conditions, it may fail to adequately prepare providers for real operational stressors. This is where modeling and simulation become especially important. Modern M&S increasingly focuses on environmental fidelity, cognitive realism, logistical constraints, communication degradation, and operational decision-making. The objective is not simply procedural repetition. Instead, simulation seeks to replicate the complexity and uncertainty of operational environments as realistically as possible. In many ways, the realism of resource limitations may be just as important as the realism of the patient itself. Several emerging technologies are significantly changing how austere medical simulation is designed and delivered. One major area is extended reality, or XR, which includes augmented reality and virtual reality systems. These technologies allow immersive procedural and team-based simulations without requiring large fixed simulation centers. Learners can rehearse scenarios in portable or distributed environments while interacting with realistic visual and cognitive stressors. Portable procedural simulators are another important advancement. Traditional simulation often depended on centralized facilities with expensive infrastructure. Portable systems allow training to occur closer to operational environments and improve accessibility for deployed personnel. Wearable technologies are also becoming increasingly relevant. Physiologic sensors can monitor metrics such as heart rate, stress response, workload, fatigue, and performance during simulation exercises. This creates opportunities to better understand human performance under operational stress. Artificial intelligence is beginning to influence simulation as well. AI-assisted systems may eventually generate adaptive scenarios that respond dynamically to learners' actions, increasing realism and variability during training. Cloud-based and distributed simulation systems are also expanding. These platforms allow geographically separated teams to participate in shared exercises in real time, which is particularly valuable for military medicine and distributed operational forces. Together, these technologies are helping move simulation away from static training centers towards more portable, adaptive, and operationally integrated systems. One of the most important shifts in modern simulation has been the transition from centralized training environments towards mobile and distributed systems, as mentioned in the slide previous. Historically, simulation often required large facilities, expensive equipment, and significant infrastructure. That model works well for institutional training, but can become difficult to sustain operationally. Mobile computing changes that equation. Portable tablets, handheld ultrasound machines, lightweight computing platforms, and mobile simulation devices allow training and decision support to occur in operational environments rather than in hospitals and simulation centers only. This is particularly important in expeditionary medicine, maritime operations, and prolonged casualty care environments. In many operational settings, connectivity may be inconsistent or entirely unavailable. Because of that, edge computing and offline capability become critically important. In austere environments, the ability to function independently of stable cloud infrastructure may determine whether a system remains operational at all. Distributed simulation also improves sustainment training. A geographically separated team can participate in the same exercise despite operating across multiple locations. This becomes valuable for maintaining readiness, especially for low frequency but high acuity skills that providers may rarely encounter clinically. Mobile and distributed simulation systems also increase accessibility. Instead of requiring personnel to travel to centralized facilities, training can move closer to operational units and deployed environments. Telemedicine is increasingly becoming a core component of austere medical operations. In some operational environments, remote consultation may be the only access point to specialty expertise. A provider operating aboard a ship in a remote operational setting or during disaster response may need to manage critically injured patients while communicating with consultants hundreds or thousands of miles away. That fundamentally changes how providers must train. Simulation increasingly incorporates telemedicine workflows into exercises to prepare teams for these realities. Telementored ultrasound is one example already being used operationally. A remote expert may assist another provider with image acquisition or interpretation despite being physically distant from the patient. Telesimulation also allows remote instruction, distributed exercises, and collaborative learning environments. This became especially visible during COVID-19 pandemic, which accelerated interest in remote learning and distributed simulation systems. In maritime medicine and prolonged casualty care environments, telemedicine may influence not only diagnosis and procedural guidance, but also operational decision-making regarding evacuation timing, resource allocation, and ongoing patient management. Importantly, telemedicine itself introduces additional operational challenges. Communication latency, degraded bandwidth, intermittent connectivity, and information overload may all affect decision-making. Because of that, simulation should not simply teach providers how to use telemedicine technology. It should also prepare them to function when communication systems are imperfect or degraded. Exercise design is arguably one of the most important modeling and simulation concepts in austere medical training. The objective is not simply procedural proficiency. The objective is preparing providers and teams to function effectively under operational stress. In austere medicine, challenges often include incomplete information, communication degradation as alluded to on the slide previous, supply limitations, environmental stressors, delayed evacuation, limited personnel, and competing operational priorities. High-quality simulation exercises should incorporate these realities directly into scenario design. For example, an exercise may intentionally degrade communications, limit available blood products, restrict imaging capability, or induce evacuation delays. These constraints force teams to prioritize resources, improvise solutions, communicate clearly, and adapt under stress. This reflects a major shift in simulation philosophy. Rather than viewing simulation only as a procedural rehearsal tool, modern M&S increasingly views simulation as preparation for complex operational decision-making. Environmental fidelity and cognitive fidelity become critically important. A technologically perfect procedure performed under ideal conditions may not accurately predict operational performance in degraded environments. By recreating operational uncertainty and logistical limitations, simulation becomes more relevant to real-world readiness. These technologies and modeling are already affecting military medical training today. Tactical combat casualty care sustainment training increasingly incorporates portable and distributed simulation systems. Shipboard trauma simulation exercises attempt to recreate operational limitations such as confined spaces, delayed evacuation, communication problems, and limited resources. Prolonged casualty care exercises focus specifically on managing critically injured patients over extended timelines with constrained personnel and equipment. Distributed simulation also allows geographically separated teams to train together without requiring all personnel to travel to a centralized location. Technology-enabled simulation is particularly important for sustaining low-frequency, high-acuity skills. Many providers may rarely encounter procedures such as damage control surgery, surgical airway management, thoracotomy, or massive transfusion scenarios during routine clinical practice. However, these skills may become immediately relevant during operational deployment. Simulation therefore helps bridge the gap between peacetime clinical exposure and wartime operational requirements. More broadly, these systems support readiness by allowing operationally relevant training to occur more frequently, more flexibly, and closer to real deployment environments. The future of austere medical simulation will likely become increasingly adaptive, immersive, distributed, and data-driven. Artificial intelligence may eventually allow simulation scenarios to evolve dynamically based on learner decisions and performance. Instead of a fixed scenario pathway, future systems may continuously adapt in response to clinical choices, physiologic management, team communication, or operational priorities. Wearable biometric systems may also become more integrated into simulation exercises. Metrics such as physiologic stress response, workload, fatigue, gaze tracking, and cognitive overload could potentially be measured in real time to better understand human performance under operational conditions. Distributed immersive environments may eventually allow globally separated teams to participate in highly realistic shared operational simulations. Advances in mixed reality and edge computing may also improve portability and offline capability for deployed environments. Another important future direction involves readiness assessment. Simulation may increasingly shift from isolated training events toward continuous operational readiness evaluation. In that model, simulation becomes not only an educational tool, but also part of how organizations assess sustainment, preparedness, and operational capability. Ultimately, future simulation systems will likely become more integrated with real operational workflows, allowing training, assessment, and readiness monitoring to all occur simultaneously. Austere medicine presents fundamentally different challenges than traditional hospital-based care. Operational environments may involve delayed evacuation, resource limitations, environmental stressors, and prolonged patient management responsibilities, as stressed many times previously in this talk. Because of that, simulation and exercise design must increasingly adapt to operational realities rather than assuming ideal hospital conditions. Emerging technologies such as mobile computing, telemedicine, wearable systems, distributed simulation, and artificial intelligence are helping expand simulation beyond centralized training centers. Modeling and simulation play a critical role in preparing providers for complex operational environments where decision-making, adaptability, and resource management may become just as important as the procedural skill itself. As these technologies continue to evolve, future simulation systems will likely become increasingly portable, adaptive, immersive, and operationally integrated. Thank you for listening to my tech talk, and I look forward to reading posts on the discussion board of any questions you may have about austere medical simulation, operational training, and future applications of all of these technologies. Thank you.